Hi, this is Elliot Fishman, and we're live on CTisus. Today is April 1st, and no, I will not give you any April 1st jokes, but I do welcome everybody here, and hopefully everybody is doing good. We are working hard on CTisus, trying to develop new content and improve everybody's experience. So I hope everybody is enjoying the stuff that we are doing. We're posting new lectures. Some of the lectures are updates of prior year's lectures, which we always do. But many of the lectures that we are doing are brand new lectures. So there's a big lecture coming up on large adrenal masses. And I'm working on a number of different things on pancreatic lesions, liver lesions. So we are trying to do a lot of stuff that people are asking for. So we are continuing to do that. Our quizzes on the website, the teaching files are growing, the content is growing. We have a lot of stuff on AI, which indeed becomes very important for all of us. So we're trying to capture a lot of AI information. If you look at the main page of CTisus website, on the right, there's a whole big thing on AIs. And we aren't doing things like, how can I say, AI for computer scientists, but AI for radiologists and radiology technologists and everyone in the field. So we welcome everybody here. I can see Jamie is home today in Glen Barney, down from Maryland, down from Hopkins. And Whitney is spring break. Yes, Whitney and Max are, I guess 12 o'clock is lunchtime. Hi, Max. Max is my grandson, and he is off from school this week because it is spring break. And next week he's back at Zoom for 1 week and then back in regular school. So I know Whitney is keeping him occupied, or he is keeping Whitney occupied. They were here last week, and that was just wonderful. So I look forward, hopefully, going up there next weekend and seeing Max and Sam and everybody. So hello. Today, our topic was cardiac CT, and I just, a couple things. So I guess by show of hands, how many of you are doing cardiac CT? A lot more practices are doing it now, though not everybody. Remember way back when cardiac CT first came along, there was the fight between radiology and cardiology. I think there's less of a battle now. Some places cardiologists do it. Most places it's radiology, then that's mainly because of the hours as well as the poor reimbursement. I think remember that cardiology originally thought that they were going to pay like cardiac cath, not just like a chest CT. So we are doing it. I've noticed with some of the new guidelines coming out, we're not doing more in the ER setting. We're probably doing the same numbers in the ER setting, but we're doing a lot more in the outpatient setting. So patients are being referred in. We're doing more calcium scoring. We're doing more coronary CTA. So that business is growing, and I wonder if your experience is the same. Calcium scoring is really growing a lot because internists know about it, and it's one more good risk factor or risk predictor for patients, particularly if you're thinking of putting patients on different medications like statins. It's a good bit of information. And remember, all the articles have been published that really show that calcium scoring is better than anything else as being a predictor of the risk of coronary disease. So it's an easy study, it's low dose. I think the volumes went down a little bit when, of course, COVID was at its peak and people weren't coming for any imaging studies. Now I think you're getting some of the makeup. Remember, many doctors' offices weren't open, and they were doing most of their medicine by telemedicine, which meant they were really working very hard on patients with acute symptoms, not so much preventive health. Now as things get better, the doctors' offices are open. Still a lot of telemedicine is happening, but I think things that measure like coronary calcium score become even more valuable. So I think you're going to be seeing a lot of that. And I see Philip Taylor, who's in Northern Virginia, saying he's doing a lot of coronaries, including lots of calcium scoring. Jason Campbell talking about calcium scoring for aortic valve stenosis. Right, we are also doing a lot of TAVR procedures. Remember, now the endovascular stent repair for aortic valves initially were in older patients, over 80, for example, because it was being developed and there was that risk reward. Now TAVRs work really, really well. And so it's the primary way of treating patients is less invasive, fast recovery, and better outcomes. So I think that becomes very important. Remember, with TAVR studies, we do a gated acquisition of the aortic root, ascending aorta, and then the whole aorta and abdomen and chest. Remember, with TAVR studies, you want to get the exact size of what the endovascular stent needs to be. And so there's precise measurements that are made from the gated acquisition. But then the whole body is scanned for several reasons. One is you want to make sure the patient doesn't have any other vascular disease that can be critical. Like, for example, if the patient has severe disease in the iliac vessels, you're not going to be able to put a catheter through there with the device, with the TAVR device. So you're going to have to figure out what else you can do or not do the study. So that becomes one of the issues. We also, since TAVRs are dealing with older patients, you also will be looking at the extracardiac portion of the exam. So it's not uncommon, and people have written articles saying up to 17% of patients will have significant other findings, be it an incidental renal cell. We picked up a couple of incidental pancreatic cancers, those are rare, abdominal aortic aneurysms, liver masses, cirrhosis, all sorts of different things. And remember, it goes back to the idea of whole body scanning. If you're scanning patients and you look at the entire chest and abdomen, you'll pick up lung cancer, you'll pick up renal cancer, you'll pick up incidental adrenal lesions, and you may pick up a lot of stuff that maybe is not important. So it's a very risk reward. But again, it's very important to look carefully at the studies. Try not to overread the extracardiac portion of the exam. That's what we've spoken about in the past. But simply, read the studies without saying cannot exclude, cannot exclude, cannot exclude. So that becomes a very important thing to do. Now, in terms of coronary CT, most of the vendors now, whether you have Siemens, GE, Philips, Toshiba, whether you have Carestream, all have software that does a very good job of analyzing the coronaries in the sense of being able to do the analysis of the vessels. And people like Cassandra, who's in Jayhawk, and John, who's in Zayed, those are two of our places. One, Zayed's the hospital, and Jayhawk is the outpatient center. Both of them do a lot of the analysis, and we do it on Siemens. And that works out very well. You isolate the coronary arteries, for example. You map them. So we see a lot more of that. We also are seeing developments in the AI era. So for example, there's now work being done at doing calcium scoring automatically, where the computer could do a calcium score on every patient, even if it's not a gated study. And there's some work going on where you could do calcium scoring even when you give IV contrast. Remember, calcium scoring is a non-contrast study because you're looking for specks of calcium, and positive contrast makes it difficult. But the density is usually a different, location is different. And so there's some work going on now which shows very nicely that you potentially can be able to do calcium score from contrast enhanced studies. And then if that was the case and the computers can do it automatically, then what you might be doing is a calcium score on every patient. Now, it may not be perfect, it's not exact as a non-contrast score that's specific for the calcium, but it can be very accurate. Articles have shown that radiologists often don't mention coronary artery calcium, and on a chest CT, when you're looking for pneumonia or PE or something, one of the most important things you can say is, what do the coronary arteries look like? Is there a lot of calcium present? Is there no calcium? The point is that as long as you're scanning the patient already, you might as well maximize the information you're able to get. And again, I think some of these things which radiologists forget about or don't always do, the computer can potentially do, and will save you time and will increase maybe reliability and some of the reproducibility. So that's something I think you are seeing. I see Lydiana's saying hi from California. Hey, Lydiana. And Lydiana's out in Palo Alto area, working in San Francisco. I think Lydiana still hasn't been back hasn't been in her new job's office in many months or since the start, which is true with many people. I think Google announced yesterday they're going to start seeing people coming in this summer, with most people back to work 3 days a week or more come September. You can argue that people have been productive at home, and that is true, but I think over time that production will decrease. I think also you have to understand that maybe a day a week or something from home is fine, but I read a good article where someone said when you work from home for a company, whatever the company is, you tend to be a consultant. You become like a consultant. You do the job, but you're not really working for the company. When you're at work, you interact with people. There's some camaraderie. There's discussions that are not necessarily the focus of a meeting. There's interactions, and a lot of discovery comes from interactions. I think one of the challenges we all face being at home, first of all, some people don't like it. I mean, right? You're sitting there. Some people have kids, so it's a little bit painful. But let's say the kids are back at school, it's less painful. But just the fact is, people like going to work. It changes your routine. You get time to think about things. You meet people. You get good ideas. There's only a limited number of good ideas you're going to get by sitting at home. Okay, and Zoom calls are nice because they do help out, and I think Zoom calls will persist even as we get past COVID for some things, right? Because we can have a meeting in the morning. We have our diagnostic imaging meeting at 7:30 every Tuesday. We used to do it once a month, and then people would come. Some people couldn't come. They're at different sites. Someone needs to be at the scanner. Well, now we have almost everybody there every Tuesday. I think maybe once a month we'll do it in person, but the other 3 weeks we're going to do it remotely because this way everybody can participate. So there are certain really good things about Zoom that are going to persist after and long after COVID is gone. But I think there's other things that really need to disappear. Now, Larry David likes to say he doesn't like people. He doesn't like to go out. He doesn't want to talk to people. So COVID is wonderful. But unless you're Larry David, it may not be such a good idea. I think if you want to meet people, if you want to learn, if you want to grow, you really need to be in the mix with people. It's also what makes things fun. I think work is a big part of our life. I think when you're working remotely, you really kind of feel like it's work. Also, I think for many of us, who are on this call, that also it's very hard to tell what day of the week it is sometimes, or so it seems. Because, it seems like every day, if you're working from home, now I'm at work, obviously, but you're working, and I like it because I can do certain things here. Also, it separates, I feel like it's much more fun. But if you're home, you begin to get a little bit stir crazy because you can't tell when the day ends, when the day begins. It's just a little bit more difficult. So I think that is hopefully going to change. So let me come back in the last few minutes, going back to coronary CT. So key things with coronary CT, I think, really relate to the technique. So you need 5 to 6 cc's injection. So you need to have good IV access. The scanners are faster, but you need to make sure the patients are well prepared for the study. It's a single acquisition, which means you got to get it right the first and only time. You can't re-inject. Patients need to be cooperative. If the patient is not holding their breath, if the patient can't follow instructions, then the odds of you getting a good coronary CT study, even with the fastest of scanners, kind of is not very likely. So protocols become critical. Post-processing becomes critical. Most of the processing can be done by the technologist, and the radiologists read it, but radiologists can do it as well. But again, with the software, it's pretty much you need to know what you're doing, but the software is much easier to use than it was just a few years ago. So I think that becomes a very, very, very important. We also do a lot of aortas, rule out dissection, rule out aneurysm, follow-up aneurysm, pre-TAVR, pre-stenting, post-stenting studies, looking for leaks, looking for complications. So that, the surgeons really rely on radiology on the preoperative and the postoperative side of things. So we really and CT have really seen that business continue to grow. I see Hazar Taban agrees that you need to be in person, and we are interested in hearing what you guys think about that, about what you plan. Now, the truth is, most people who will be on this call, technologists, you're not, the only people who are at home are the administrators. The technologists are at the scanner. They've been there since day one. In theory, you can scan remotely. That's in theory, but you can't scan remotely. You need to be there. And so the techs, we've said this before, the techs are the real superheroes of the COVID era. They were there even when there was low supplies of masks and everything else. So the techs have just been incredible in getting the work done and really dealing with often very, very sick, very difficult patients. So we cannot give them enough credit, and it's just something that we always will remember. And hopefully many hospitals around the country, there was an article in the paper today, they mentioned Mayo Clinic and a number of other hospitals have made more money than ever in the COVID era because hospitals were getting paid more for COVID patients. Hospitals were able to cut expenses and more efficiency. So hopefully hospitals making more money will remember the employees who work there and give them raises or bonuses or something, a couple donuts. I don't know, but you don't want donuts, and I'm not being sarcastic, but I think, perhaps as people look at their books and see these profits they've made that were substantially more than they expected to make, that perhaps the staff, whether it's in radiology, whether it's in oncology, whether it's in medicine, the ICU, whether it's nursing, or even people who move the patients around, the transports, the technologists, the lab technicians, everybody. I'm not just picking on radiology and saying radiology technologists should be rewarded, which the answer is they should, but there are many people, nursing again, just really did their job. So I think we're not over the COVID era yet. Obviously, I don't think, where's my mask? I have to go get some coffee, but so here's my mask. But I still think, I'm hoping a year from now we're not going to be wearing masks in the hospital, but I don't think that's going to change in the short term. I think people are going to come back to work, but you're still going to maintain social distancing and you're still going to be masking. So I think that's just not going to change for a while. I'm hoping by first quarter, no worse than second quarter next year, we will be maskless, maybe, the way to look at it. As of today, about 25 or 26% of the U.S. population has gotten their vaccines. Remember, they speak about the fact you need 85% to get herd immunity. Remember, at this point, children still aren't getting vaccinated. No one under 16 is. Though there was great news from the original results from Pfizer on 12 to 16-year-olds, where the vaccine was like 100% successful. They're going to the FDA. Moderna, Pfizer are all looking at the 6 months to 2 to 6 years group of kids, and those trials have already started. The goal is for many of the kids to be able to give them a vaccine by September. Some colleges now have already said that they will not let you on campus in September without a vaccine. And vaccines are approved for 16 and over, so that should not be a problem unless you're a child prodigy and you go to college at age 9. Then you may not be able to go to class. But hopefully, I think by the end of 2021, you'll be able to have a vaccine for the children below 12. I think it's going to be really tight to make that happen. I think it will surely happen by the end of the year going into 2022. And I know as for parents who are on the call, grandparents, even if you're vaccinated, you worry about taking your kids somewhere. So I think till everybody in your family is vaccinated, it's always going to be a little bit of discomfort as to what exactly is going on. Now, let's see, Jay mentions flagels. I bring flagels in. I'm buying black and white cookies, you see, because I can get them shipped here, and you can't have anything that's not wrapped. And the bagel place that I buy flagels, which is Goldberg's, I have no interest in Goldberg's, but they don't wrap anything. So you got to take it, put it in a bag, and I'm not going to one who's going to sit there wrapping them. I can tell you. But I think the black and white cookies from New York by Goldbelly those will be wrapped. So I think April 6th, I'm supposed to get the cookies. We spoke about this yesterday. So anyway, I think my time is up. I'm running a little bit long. If anyone has any questions, this is a great time to ask it. If not, you can ask us after, and we'll be happy to answer them. And again, we are creating a new series of talks on cardiac CT. Hope you find that helpful, and we are going to have a lot more cases that are being put on the website. So with that, I thank you for your attention. I hope you have a great April 1st. I hope no one has fooled you yet today. And with that, oh, by the way, I'm taking a vote. How many people, I've grown a beard, or sort of a beard. This is the most hair I've had in my life. So we'll have to see what happens. If I got my hair cut here, should I keep the beard? Maybe we'll vote on it. The question about December 2021 meeting in Orlando. Yeah, I think that, I don't know, that meeting, I think the goal is to have it in person. I do believe that for the next year, a lot of the meetings that are in person will also be virtual. I think there's going to be some type of a hybrid approach. I think it's not going to be all one or all the other, but we shall see as it gets a little bit closer. So with that, have a great day.